انا مايكل عبيد، برودكت مانجر شركه ساندوز. احنا دلوقتي السيشن دي اور سيمبوزيوم، ساندوز سيمبوزيوم. هيشرفنا فيها الاستاذ الدكتور حسن شاكر، هو حالا هيكون موجود في وسطينا. استاذن حضراتكم لو تسمحوا لنا ان احنا تفضلوا يعني تكونوا موجودين، والناس اللي واقفين ورا يتفضلوا يقعدوا. احنا ساندوز الحقيقه يعني بنتشرف جدا ان احنا دايما نكون معاكم في المؤتمر، بيبقى شرف كبير لينا. ويعني ساندوز بنعتبر نفسنا بارتنرز مع جمعيه الجراحين ومع كل الساده الافاضل الاطباء اللي مشرفينا النهارده. يعني لو تسمحوا لنا ان احنا النهارده يبقى الوقت اللي جاي ده يبقى فيه ان شاء الله بروفيسور حسن هيقدم لنا سيشن قويه جدا عن بروفيلاكتيك انتيبيوتكس ان سيرجري. واحنا الحقيقه يعني كانت بالاتفاق مع بروفيسور حسن كان ده اختيار المحاضره، لان ده اكتر مجال احنا بنشتغل فيه كشركه ساندوز في المجتمع المصري بالبرودكتس بتاعتنا. فذاتس واي اهتمامنا كتير جدا ب how to use the antibiotics in the right way according to the guidelines. وده اللي ان شاء الله هنتشرف ببروفيسور حسن هيقدمه لنا النهارده. ويعني انا هكتفي بالكلام ده، المستر تشيرمان يقدمه.
We will run quickly to the next lecture. I have the honor to introduce Professor Dr. Hassan Shakir, the General Surgeon and the late Head of the Surgery Department in Shams University. The talk will be about the prophylactic antibiotic in surgery. Professor Dr. Hassan.
Thank you so much, Professor Mustafa, for the nice introduction. And I want to thank, of course, the organizers and the chairman of the Egyptian Society of Surgery for inviting us for such distinguished meeting as usual. The subject we'll speak about is an old and new subject, prophylactic antibiotic in surgery. We all give prophylactic antibiotic around perioperatively around our operations. But do we actually administer the proper antibiotic for the appropriate operation at the appropriate time? So we review together, why do we give prophylactic antibiotic? Of course, we give it to avoid surgical wound infection. Surgical wound infection might be simple, as this one, might be moderate, or might be severe and reach this figure, which we all hate to see our wounds like this. What's the problem? The problem that post-operative wound infection, although we might consider it as one of the least complications after surgery, but actually it affects the quality of life of the patient as well as the economy of the healthcare. The consequence ranges from pain till severe wound care, sepsis, septicemic shock, and sometimes death. The incidence, for example, in the United States is about 1 million patients per year get one wound infection. The average hospital stay increases and the cost as well increases by 20%. The cost last year cost the healthcare system in USA $2.5 billion for the consequences of the wound infection. So what operation do we give antibiotic before or at the operation? By logic, it is the clean, contaminated and dirty operations. But what about the clean operations? Do we have to give? Clean procedures forms about 60% of all the procedures, the surgical procedures we do. But at the same time, about 40% of the wound infections are basically clean surgical operations. And the prophylaxis for the clean procedures reduces the overall wound infection by about 17%. What type of antibiotic do we give? Usually what do we do, that we tell the anesthesiologist or even the registrar, give him 1 gram of anything, give him 2 grams of anything. The term of anything, I don't think it is a proper one. We choose a prophylactic antibiotic according to the procedure, according to the organ we are operating on. So, according to the organism, we can the expected organism to be affecting our wounds, we can design our antibiotic administration. For example, in the GIT procedures, oral and intravenous antibiotics against gram-negative and anaerobic bacteria, because usually if the small intestine is open, this is the proper. And in the large intestine, we have to add the mechanical bowel preparation as we'll speak later on. So, is it sufficient for wound infection? Yani, do I am satisfied to give the patient prophylactic antibiotic and I say there will be no infection? Of course not. We have to follow the other measures that avoid infection. It is not only giving the antibiotic. The other measures starts with the preoperative control of comorbidity, like diabetes mellitus, like immunodeficiency, morbid obesity, dental caries, any site of concomitant infection. Shaving, the proper shaving at the site of the operation, which I know that some might ignore it. And the shaving, sometimes we use the razor in most of the cases. And recently, the preferred way of shaving of the patient is by the clipper. But if we use the clipper or if we use the shaver, both might differ slightly. In the statistics, they showed that, or concluded that the clipper, the overall wound infection is less with using the clipper than the shaver. But what about the timing of the shaving? It appeared that if we use the clipper, the best results are to give it in the morning of the operation, but if we use the razor, it is the opposite, to give it the night before the operation, to shave the night before the operation. Hand washing, the proper hand washing, of course, before putting on the sterile gown. The proper skin cleaning and the proper draping and the design of the sterile drape according to the operation and the incision I am going to incise. The proper operative environment. The operating room is usually divided into the sterile area where the sterile people are present and the non-sterile area where is the anesthesia, and the other that's for the circulating nurses and the circulating, like this assistant putting his head almost in the wound to watch the operation. So we have to respect the proper environment. The sterile area is sterile, the asterile area is asterile. In handling from the circulating nurse, of course, we have to follow the proper rules in order not to touch anything not sterile. Added risk factors to these measures are systemic and local. The systemic include any remote infection, as I said, comorbidity like diabetes, morbid obesity, extremes of age, malnutrition, etc. The local factors include if we use prosthetic devices like mesh or artificial heart valves, if the operation is lengthy, the length of the operation is important in selecting both the type and the dose of the antibiotic. Excessive use of electrocautery, which we sometimes use it to stop any ooze, but the excessive use of electrocautery invite infection. Local injection of anesthetic, if we add epinephrine in more doses, this causes vasoconstriction and consequent infection. If we use wound drains, especially the open system, not the closed, and if this area or this wound was previously opened or radiated upon. If any of these two factors are present, the risk of infection increases by 4 folds, and this is called the risk index. This is the classification of wounds with the incidence of infection, starting with the clean wounds, the least, and ending with the dirty, the most incidence of infection. How do we select the antibiotic? To select the antibiotic, at first, as we said, that we have to check the system we are operating upon. So the antibiotic should be effective against the organism expected to be in this operation. The second factor is that a high concentration, to ensure high concentration of the antibiotic in the tissue. The antibiotic should have the minimal side effects on other organs, and if possible, to be not that expensive. The factors influencing our choice is the microbial infestation of the wound and the hospital environment. So it depends upon the hospital you are operating in and the environment in the hospital. You might add or you might remove from the antibiotics. The Staphylococcus is the most common procedure, the most common microbe in the most of the procedures that where the intestine or where the hollow viscous are not opened. So in general, for the staph, which is in most of wound infections, especially in the soft tissue, quinolones or second generation cephalosporin are enough for prophylaxis. For procedures in the GIT or the urinary tract, we have to add antibiotic acting against gram-negative and anaerobic microorganisms. In such cases, third or even fourth generation of cephalosporin, like vancomycin, with added metronidazole or clindamycin. Quinolones also may be effective against gram-negative organisms as well. The timing of administration. It is usually an error that we ask the registrar, give the patient 1 gram of antibiotic before going to the theater. Before going to the theater might be 2 or 3 hours before the operations. So in different researches, we concluded that the appropriate or the most time for the concentration is within 1 hour before the skin incision, before putting your scalpel. So the best time to administer the antibiotic is to tell the anesthetist when he starts the induction of anesthesia to give the antibiotic at the same time to reach the maximum level within the 20 or the 30 minutes when you start opening your wound, your incision. So the ideal is 30 minutes from the operation, and if the operation is lengthy, we can add another dose 1 to 2 times according to the half-life of the drug. In some operations, especially in the major operation, or if we are operating on a traumatic wound, or after GIT operations where the viscous is opened, we can continue the antibiotic after operation as well. This example for the half-life of different antibiotics available. There are some recommendations for the specific procedures according to the system or the area I am operating upon. For example, in the soft tissue procedures, if it is superficial, like sebaceous cyst or lipoma or something, there's no need for prophylactic antibiotic. But if there are 2 factors, or the systemic or the local factors, added factors I just mentioned, we might give 1 dose of prophylactic antibiotic. In traumatic wounds, it is not the antibiotic administered, but it is the mechanical cleaning and debridement of the wound before giving the antibiotic. So if it is a trauma, motor car accident, or is trauma in the street, we have to properly clean and proper debridement of the wound and give also the prophylactic antibiotic. And in such cases, it is second generation antibiotic is enough, second generation cephalosporin or quinolone. For head and neck, if we are not opening the trachea or the esophagus, we deal with it as the soft tissue. For example, in the thyroidectomy. Cephalosporin, second generation cephalosporin is enough perioperatively, but if the oropharynx or the esophagus is opened, we have to add antibiotics for the aerobic cocci. For the oral surgery, for example, for the dental surgeons, there is no need of for antibiotic if they are working on the dental or the alveolar area inside the mouth. For GIT procedure, it depends whether I am operating on the upper GI or on the lower, on the colorectal. So if we were working on the stomach, the duodenum or the proximal small intestine, routine prophylaxis as usual is enough. But in cases of atrophic gastritis or decreased gastric acidity, the risk of infection is increased if we are doing gastrectomy or gastrogenostomy, for example. The prophylaxis is also indicated in case of massive GIT bleeding, in case of intestinal obstruction, because in such cases the patient immunity is less and the infestations with the microorganisms are more in case of obstructions. In such cases, microlide, quinolones, and cephalosporins are the recommended antibiotics. What about the colorectal procedures? The colorectal procedure, of course, carries higher risk of infection than the proximal part of the gastrointestinal tract. So prophylaxis against gram-negative anaerobe and anaerobic bacteria, both parenterally or enterally. But is this sufficient? No, we don't ignore the mechanical preparation. The mechanical preparation of the colon. So we have to give parenteral or oral antibiotic or antimicrobial, in addition to the mechanical wash and mechanical preparation of the colon in addition. For appendectomy, we deal the same as the proximal GIT exactly. And for the laparoscopic, the last thing, it was the last slide, for laparoscopic procedures, both thoracoscope and laparoscope, we think that this is minimally invasive surgery and these are minute wounds, but we have to deal with them exactly as open surgery with the same parameters and the same protocols just mentioned. Thank you so much.
Thank you, Professor Dr. Hassan. Any question, one or two questions? Professor Dr. عبد المعطي اتفضل.
لا مش هخلص معاك يا بيه. دكتور عبد المعطي الملك في الموضوع ده اصلا.
Thank you very much Professor حسن، والله مبسوط جدا من الكلام. بس ليا كومنت وحيد. هو في الكلين اوبريشنز we don't advise prophylactic antibiotic except if there is prosthesis زي ما حضرتك قلت، أو if the patient is high risk for infection. يعني عنده liver disease, kidney disease, hypoalbuminemic, cardiac، كل الحاجات دي وهو بيعمل clean operation should receive antibiotic. عندنا بقى في القصر العيني كل العيانين اللي بيجوا لنا for clean operations have these characters. That's why it is obligatory in our hospital to give a clean operations prophylactic antibiotic. بس thank you.
انا قلت لحضرتك حسب المستشفى، يعني حسب المكان اللي بتعمل فيه العمليه، لو مستوصف وناس داخله برجليها كده من بره من الشارع وبتاع، مختلفه خالص عن ما تكون major hospital with clean and aseptic measures taken from everybody.
دكتور حسن بيه شكرا جزيلا على انا بس ليا سؤال على الكولونيك بريبريشن still do you like chemical and mechanical preparation although it is against ERAS and changing bacterial flora and starting oral intake as early as possible. What's your plan?
بص يا دكتور سليمان بيه، يعني احنا مش خسرانين حاجه ان احنا نعمل الميكانيكال بريبريشن للكولون، ولكن دلوقتي الترند الجديد طبعا اذا الكولون اتفتح وكان ما هواش بريبيرد ولودد، احنا بناخد فيه دلوقتي خلاص ستيتشز، ما عادش زي زمان بنخاف ونعمل كولوستومي. لكن ما تاخد حضرتك احتياطاتك اكتر you will decrease the incidence of infection as much حتى لو كان minor infection. فواي نوت اذا كانت بلاند اوبريشن والعيان هنشتغل على الكولوريكتال اريا، واي نوت ان احنا نديله فرصته ان هو نعمل بروبر ميكانيكال بريبريشن مع الاورال مترونيدازول او نيومايسين وات ايفر.
هو احنا زمان واحنا يعني في الثمانينات كنا بنعمل 3 ايام ام بي او وانيما ومترونيدازول لكن احنا دلوقتي 1 انيما اوفر نايت العيان بياخد اورال فلويد عادي خالص، 1 انيما كليننج بس مش ووش اللي هو نغسل العيان وندخله في ديهايدريشن والكترولايت ونغير البكتيريا، هي 1 انيما فور كليننج زي ما حضرتك بتقول از انف.
بس ستيل برضه لو العيان ما هواش ويل بريبيرد في الكولون، ستيل الريسك of an stomatic leak and infection is still higher than if he is prepared. انا مع حضرتك ان معظم الحالات بتعدي من غير ليك، لكن ستيل برضه الانسيدنس في انسيدنس لو كان عيان ما هوش بريبيرد.
يعني الحقيقه الكلام بتاع الإراس وال
يعني ما انا هقول لحضرتك حاجه، يعني انت هتبقى مبسوط وانت بتعمل انستموزز والستول قاعد يخرج. اي دونت ثينك ان الكلام ده صح ابدا. يعني زي ما بيقول البروفيسور دكتور حسن، يعني احنا مش هنخسر حاجه في البلاند اوبريشن ان احنا الميكانيكال ريبير يعني.
خصوصا في الكولد كيسز، لو امرجنسي خلاص هنشتغل وهنعمل انسموزز وكل حاجه وناخد احتياطاتنا، انما لو
انا
كانت
اقصده بس
cold
عشان
why
تبقى
not؟
مسج لو في حد من الجونيور انه مش لازم قعد العيان 3 ايام ام بي او، مش لازم
لا ولا
نهج
3
العيان
أيام ولا
3
حاجة يا
انما
بيه، ده
اوفر يعني فريكوينتلي.
لا يا
يعني ده
فندم.
بيضر العيان اكتر ما بيفيد
لا لا، ده هي 6 ساعات كده لتر مانيتول او 12 كيس ابيماج على لتر ميه، وعلى 5 6 ساعات يكون عمل الكليننج وكل حاجه، يعني مش محتاجه 3 ايام زي وبس، وكلير فلويد ليلتها وخلاص. يا فندم اتفضل.
هو ليه يا ريت تقول لنا مسج الانوريكتال سيرجري، واحد يعمل مثلا هيمورايدز فيستولا انال فيستولا فيشر وبنعزقه انتي بايوتكس، وات از يور مسج؟
لا يا بيه، احنا حضرتك علمتنا ان ما نديش
لا.
انتي بايوتكس في
لا،
الانال
لا، أصل
اوبريشنز.
في
لا ده بناء على طلب
مليوس
المريض يا
جداً.
فندم. القصه دي مشكله ان العيان بعد الانال اوبريشنز بيبقى في عنده روونز، فالروونز دي بتؤوز في شويه سكريشنز بتنزل، العيان بيفتكر ان ده انفكشن او بيفتكر ان ده بليدنج، بيفتكر ان ده باس، واحيانا لو كانت نازله هي بلادي شويه بلاد اوز شويه فبيفتكر ان ده بليدنج، يقول لك انا عندي سديد عشان انت ما تديش مداد.
بالظبط، يعني هو البيشنت
فبنضطر ان احنا ندي المداد عشان خاطر العيان بس، انما ساينتفيكالي طبعا
يعني
حضراتكم
no
طبعا
antibiotics
الاساتذه اللي
في
علمونا ان احنا ما نديش انتي بايوتكس بعد الانال
بس
اوبريشن.
لحد دلوقتي زي ما حضرتك عارف انه بيستعمل كتير.
ما انا بقول لحضرتك فور ذا بيشنت ساتسفاكشن يا فندم، فور ذا بيشنت ساتسفاكشن، انما مش يعني ساينتفيكالي مش مظبوط.
شكرا.
ثانك يو، شكرا بروفيسور.
ثانك يو.